the nursing educational coordinator for this program. We welcome you to this evening's CME activity, Women's Health Update. The program this evening will provide 1.5 hours of Category 1 AMA physician CME credit and 1.5 hours of Virginia Nurses Association CE credit. Sovah Health is accredited through the Southern States CME Collaborative for providing Category 1 AMA CME physician credit. It's also accredited by the Virginia Nurses Association for nursing CE credits for programs. This program was developed to promote certain desirable physician attributes, including our providing patient-centered care and utilizing evidence-based medicine in our practice. The reason or the educational needs for this program came from our annual needs assessment survey that we do each year. Dr. Evans, Dr. Greer, myself, and members of the Sovah Health CME committee have nothing to disclose as regards any commercial relationships we may have with what in the CME world is known as ineligible companies. This program does not have any commercial support. Instead, it, like all of our Sovah Health programs, is supported by an educational grant from the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the Southside Urology and Nephrology practice, previously known as the Danville Urologic Clinic, established this fund upon his retirement from clinical practice, and it provides financial support for speakers, their honorarium and travel, for education for our community of healthcare professionals. The fund supports not only physician, nursing, nurse practitioners, CME, but also dental, EMT, and other types of healthcare professionals. You will receive this evening by email, and or you can activate it, as I'll show you in a minute, through a QR code, a program evaluation form. It has some 7 questions or so. We ask everyone to take a few moments to complete that. As part of that evaluation form, you are asked to re-enter your name and your email. Please give us your full name, because that's the name that will appear on your CME or CE certificate. So no nicknames or short names. In addition, I always like to bring to everyone's attention question number 4, which asks, what changes might you be making or will you be making based on what you learned in the program this evening? That's for everyone that does an eval form, not for just the providers. We all practice our skills within our scope of practice. So take a few minutes, answer the questions thoughtfully. We utilize this information extensively to try to continually improve our programs and plan for future activities. If someone's on the call with you on your registration link, as it were, please let one of us know about that so we can be sure the person with you gets similar credit. Mary will put up in the chat at the end of the program a QR code. If you like to use that approach, you can snap the picture of the QR code, and it will provide you the evaluation form also. We always remind our residents, Sovah Health Medicine residents, family and internal medicine, that you do not have to keep up with your CME certificates. Your program coordinator, Dara Johnson, or Lori Galvez tracks your CME participation. It's of note that physicians are not required to do an eval form, though we very much appreciate everyone doing one. However, for nurses and nurse practitioners, the Virginia Nurses Association requires you to complete an eval form in order to receive credit for your participation. I want to thank Mary Kent and Jennifer Goodman for their help in developing and are putting on this program this evening. They really do the majority of the work that allows us to provide CME programs for our healthcare community here in Southside Virginia. I know that both our speakers would love for you to ask questions or make comments. You can do that by raising your hand in the chat or typing it into the chat, or just speaking up. They're going to ask for questions from you periodically. If you do ask a question verbally, if you speak it, once you've asked your question, please mute your phone so we don't get feedback. And you're more than welcome to do more than one question, more than one comment. That really adds so much more to the presentations when some sort of dialogue or conversation can begin. I want to highlight one more upcoming program for you that will be next month. Periodically, about every other year, we do a medical malpractice update in which we have an attorney who's experienced in healthcare law talk about what, if any, there are in new laws regarding medical malpractice actions in the Commonwealth, and also review what's been happening over the past 18 months as far as things that led to medical malpractice actions and the settlements or verdicts or whatever that resulted. Neil Lewis is a partner of Hancock, Daniel, and Johnson law firm, which is a very large Southeastern law firm based in Richmond and other cities. They have been very active over the years in defending healthcare professionals in malpractice action. He's an excellent speaker, active litigator in his work, and I recommend this program to everyone that may be able to attend. So this evening, we're delighted to provide what we're calling a Women's Health Update with two excellent speakers this evening. Both are from the Carilion Health System in Roanoke, which you know is also part of the Virginia Tech School of Medicine program with Carilion. There will be two speakers, as I know you know. The first will be Dr. Sarah Evans, and then once she's made her presentation, I'll tell you a little bit about Dr. O'Connor. Our first speaker did the majority of her professional education at the University of Virginia, including her undergraduate degree in biology and then her MD. As a medical student, she was selected for Alpha Omega Alpha AOA, which is the honor society for top performing medical students in medical school. She then completed her residencies in OBGYN at UVA and then spent several years in fellowship for female pelvic medicine and reconstructive surgery at the Carolinas Medical Center, which is now part of Atrium Health in Charlotte. This resulted in her being doubly board certified in urogynecology and reconstructive pelvic surgery, as well as OBGYN. She has received numerous awards for her work. She has had numerous teaching recognitions, publications, and scholarly presentations, both locally, nationally, and internationally. She's a reviewer for the International Urogynecological Journal. And one of the nicest recognitions she's received was the Association of Professors of GYN in Humanism's Teaching Award, which basically recognizes her for her sharing of her expertise in fostering hands-on learning environments for students and residents in training. So we're delighted to have Dr. Evans talk with us this evening. Dr. Evans, if you will bring and share your slides, it will knock mine off and we are ready to go. Thanks so much.
All right. Thank you for having me in that introduction.
They look good, Dr. Evans.
Looks good. Okay. All right. Well, my objectives tonight are hopefully we will review some newer treatment options available to women with urinary incontinence. Specifically, there's some newer surgical options that are minimally invasive that I'd like to share with you all. And we'll also talk about urinary tract infections in women and how we can help prevent them. And whenever I'm given an opportunity to speak, I like to talk about the genital urinary syndrome of menopause and how that fits into all of this. Here we go. Ask me questions along the way. Okay, so pelvic floor disorders refer to either urinary incontinence, bowel incontinence, or pelvic organ prolapse. They're very common, so 44 million women in our country will have at least one of those disorders by 2050. And right now, 1 in 4 women will have at least one of those disorders. There's a delay of the slide, sorry. Okay. Even more common is the genitourinary syndrome of menopause. So this refers to symptoms that result from the lack of estrogen and androgens in the lower urinary tract and vagina that happen with menopause. And they affect at least 80% of women who are menopausal, postmenopausal. And they tend to become more severe the longer a woman is without estrogen, so that the longer she is in the postmenopausal transition. And some of these symptoms include urinary incontinence, urinary urgency, frequency, painful urination, true recurrent episodes of cystitis, or just feeling like she has a urinary tract infection with negative cultures, painful intercourse or irritation and pain in the vagina. So let's talk about stress urinary incontinence first. This refers to urine leakage that happens to women every time they exercise, or they cough, or they laugh, or they go to the trampoline park with their kids. It's very common, but there are many different treatment options available to women for both non-surgical and surgical. So there are some behavioral changes we'll talk about. Pelvic floor physical therapy for this condition really focuses on strengthening the pelvic floor muscles. There are continence devices called pessaries. That's what this picture here shows. These are a medical grade silicone, soft, flexible plastic device that we can fit women for in the office. And they can be used as needed. So women will wear them just when they go for a jog or when they go to the gym. You can order some versions of these on Amazon now, but obviously I would always strongly encourage women to seek out someone who can, fit their bodies for one that fits them perfectly. And there are some continence pessaries continence tampons that are available over the counter for women. And then there's surgery. So for behavioral changes, the behavioral change we know that is most effective for women with stress incontinence is weight loss. So this was called the PRIDE study. This was a large randomized controlled trial. It randomized overweight and obese women with stress urinary incontinence to an intensive weight loss program and some education about urinary incontinence versus the education alone. And at 6 months, the women in the intense weight loss program lost an average of 8% of their total body weight versus nothing in the other group. And that resulted in an almost 50% reduction in their urinary incontinence episodes per week. So that's a nice number to be able to show women their weight today, what would 8% less look like, and what a great improvement in your symptoms you could see with just this amount of weight loss. And it's also worth noting that a 50% reduction in urinary incontinence is the same result they could expect to see after seeing a trained pelvic floor physical therapist or by using a pessary. So let's talk about surgery. So over time, there's been over 1,000 different surgical procedures described for stress urinary incontinence, but only a few have withstood the test of time. So we have level 1 evidence to support the safety, efficacy, durability of what I call the oldies but goodies. So the first is called a Birch, urethropexy, colposuspension, retropubic suspension, lots of different terms for it, but most women would say they've had a Birch before. This is a surgery that I do robotically. It does not involve any mesh. It's permanent suture that's placed on either side of the urethra and suspended basically to a ligament that runs over the pubic bone. So that's one. The other is an autologous fascial sling or bladder neck sling. This is when a piece of abdominal wall fascia or thigh fascia is harvested and placed under the urethra to support the urethra. And then what most people are familiar with is the TVT sling. It's a synthetic mesh sling, midurethral sling. When most women come to me saying they've had a bladder tack, they usually mean they've had a TVT sling. And then some newer treatment options available for women that I'd like to touch on today include the single incision or mini slings and urethral bulking. So the TVT sling is still what we consider the gold standard. So it was first described in the 1990s. It's minimally invasive. There's one small incision I make in the vagina under the urethra, and I pass a piece of permanent mesh material that you can see in that picture on either side of the urethra. And the idea is that it reinforces those periurethral support structures that are lacking in women who have stress incontinence. or that have been injured, like by childbirth or menopause or whatever it is that's causing it. This surgery takes me about 20 to 30 minutes to do, and women can go home the same day. It is a type 1 wide pore polypropylene mesh. It has undergone many post-market surveillance studies to prove that it is safe. It is not the same mesh as the vaginal mesh prolap kits that were banned for sale and distribution in 2011. And that's a whole nother conversation that we could have. And it's tension-free, meaning the mesh is ultra lightweight, so it does kind of move with a woman's body, which equates to less voiding dysfunction, less retention than some of the other procedures like the Birch procedure or the fascial sling. The TVT sling also works really well. So 80 to 90% success rates, 70 to 80% cure rates. You know, everyone wants surgery to cure something, but surgery never cures anything. And the TVT sling actually does cure stress incontinence. So it's nice to be able to offer that to women. And what this graph shows is that it works well regardless of the severity of stress incontinence. So whether she's had surgery for this before, whether she has what's called intrinsic sphincter deficiency, which means her leakage is so severe she like gets up from a chair and leaks, it still works well for these women. But obviously it's not completely without risk. So there's kind of two versions of the TVT sling. The first picture I showed you, the mesh has a retropubic trajectory. So it kind of comes out right above the pubic bone. And this picture here shows a different version that has a transobturator approach. So it comes out through the groin. And I mention that only because the surgical morbidity you see listed here, it just depends on which type of sling, but both are the TVT sling that's considered gold standard. So up to 3.8% risk of bladder perforation with the retropubic approach. And I actually read a study that if a resident does the procedure, that number, you can multiply that number by 10. Groin pain and up to 20% for the transobturator approach. Mesh erosions, meaning one day the mesh exposes itself into the vaginal wall in 3 to 4%. Women who smoke cigarettes have twice the risk of that. Mesh erosions can be managed expectantly if a woman is not symptomatic and not sexually active. It can be managed with local estrogen or trimmed in the office. There's about 1% risk of reoperation. So it is not a life-threatening complication, but obviously one that women really do worry about. There is still some risk of needing a catheter for some period of time after the surgery. And bigger complications like large blood clot, major vessel or organ injury, need for post-op laparotomy or laparoscopy are much more rare. But the reason I mention that is because the single incision slings that are now available to women, also known as a mini sling, is an attempt to even further decrease the surgical risk associated with such a successful procedure for women. So it's a shorter piece of mesh. I make the same incision in the vagina under the urethra. The mesh passage does not come out through the skin. So it has these little anchors that anchor themselves in the obturator membrane. So it pretty much, it'd be very difficult for you to perforate the bladder, not impossible, but difficult. Significantly less bleeding, none of the groin pain that women experience with the other ones. So it's an attempt to make this an even safer procedure for women. When these first came on the market, everyone's kind of initial reaction was that they didn't think there's any way for this to be as effective as the slings that we had been using previously, especially because those had worked so incredibly well. But we do have some data now. This was a study out of the UK with 3-year outcomes. It was a non-inferiority study comparing the single incision slings to the standard, gold standard TVT sling. And the mini slings did meet both subjective and objective criteria for non-inferiority at 3 years. And this was, I think, almost 300 women in each group. It's also been looked at in a couple of Cochrane reviews. So this Cochrane review was comparing the mini sling to the retropubic slings and showed similar cure rates at 12 months without an increase in complications. And when compared to the trans-obturator, again, similar cure and improvement rates at 12 months with some improvements actually in risk. So less mesh exposures, less urinary retention, and less pain at 2 years. So the take home from this is that I think it's a nice surgical option to be able to offer women. We're using it more and more now. Probably works as well as our traditional TBT slings with less surgical morbidity. Which leads the way to an even less invasive option for women who have stress incontinence, and this is called urethral bulking. So urethral bulking has been around for a long time. This is something that's performed cystoscopically, so meaning I use the cystoscope camera. It has an operative channel that I put a really long needle through and inject some kind of filler agent into the urethral mucosa to try to bulk the urethral lumen and make it more difficult for urine to leak. There's been probably 25 different options for what we use as that filler agent that have been introduced at different points throughout time. And they've been studied really well. There's a big Cochrane database review in 2012 that showed basically none of them work much better than placebo. None is any better than the other. And while women may note improvement rates as high as 80%, like immediately after the bulking procedure, they're down to 30% at a year and then pretty much gone at beyond a year. So women would need some repeat injections. So traditionally, I thought of this as like a salvage procedure. Like we've offered women everything else, or a woman is so unhealthy, she's not a candidate for anything else, but her leakage is just so severe. I'm trying to do anything to help her. But a pretty limited role historically for bulking. But then in 2020, excuse me, the FDA approved a new agent for urethral bulking. It's called Bulkamid. It's something that I think women are hearing about on social media. They come to me even asking about it. But the nice thing is that it does seem to actually work. So as opposed to the other particle-based agents, I just listed some we've used in the past because it's interesting the things we inject into women. So carbon-coated graphite beads, calcium hydroxyl acetate crystals, a polyvinyl product. Those were kind of like the original versions that I've used since my training. But the gel-based is the new one. So this is almost all water and then has this like hydrogel matrix associated with it. And it seems to work. It also seems to work for a longer period of time. And the thought process is that this gel-based fiber cross-links make it a more durable filler that you're placing in the urethra. But I also think that they have their own proprietary cystoscope that I showed in this picture that makes for a really nice, reliable, and reproducible coaptation of the urethra, which I do think is part of the reason why it does seem to work. So it has been studied in a randomized controlled trial comparing it to the TBT slings, which again are our gold standard. This is a 3-year outcome study, but we now actually have a 7-year outcome study. And it was a non-inferiority study. And while Bulkamid did not meet the criteria for non-inferiority when compared to a sling, which I don't think surprises anyone, what I think is important is that satisfaction rates at 3 years were as high as 90%. And negative cough stress test, meaning you couldn't get them to leak in the office, was as high as 78%. And that's pretty unheard of for a bulking product. And in the 7-year outcome data, that those satisfaction rates and the negative CST rates are like 50 and 60%. So that's really very high for 7 years after urethral bulking. So I am excited to be able to offer women this product and tell them that it might actually help. Okay, so let's switch gears from stress incontinence. We can talk about urgency incontinence and overactive bladder. So overactive bladder is a constellation of symptoms, including urinary urgency, frequency, meaning voiding 7 or more times a day. Nocturia means waking up 1 or more times a night to urinate, and that can go hand in hand with leakage, or they could just have these symptoms without incontinence and it's still overactive bladder. And importantly, this is in the absence of a known neurologic condition that's causing this, or another obvious medical condition like diabetes or recurrent cystitis, or MS or something like that. Then we call it neurogenic bladder. And we're not talking about that today. So the American Urologic Association has a really nice algorithm that anybody can Google and look up online that I like to print out for women, that talks about basically how you evaluate this and how there is an algorithm for treatment, which I think is helpful for patients to know that there are first and second and third line treatment options available, so not to become discouraged when things are not working for them right away. First line, of course, are behavioral. So the main thing is be careful what you're drinking and how much you're drinking. So, sodas, carbonated beverages, caffeine, all of those things will cause urinary urgency and frequency. Bladder training, meaning timing or voiding on a timed schedule and suppressing the urgency in between, strengthening your pelvic floor muscles. Pelvic floor physical therapists are excellent at coaching women through these things. And then also weight loss can improve urgency and continence as well as stress incontinence. So that's first line. Second line treatment options are medications. And there's two major classes of medications for overactive bladder. The antimuscarinics or anticholinergic medications have been around for forever. Most people are familiar with them. Oxybutynin is even available over the counter as a patch. They do work. Women can see improvement rates is up to 60% on these medications. It does require them to be pretty diligent about taking them. It takes up to 3 months to see maximum efficacy from these drugs. And the problem is they have such high side effect profiles and awful side effects that most women do not tolerate them for 3 months to really achieve the efficacy rates that they offer. Some ways to try to minimize side effects are to prescribe the longer acting medications as opposed to the short acting, or to switch from one antimuscarinic to another because there's no really reproducible effect. Like a woman may have terrible dry eye on oxybutynin and then tolerate tolterodine, but her sister may have the complete opposite reaction. So it's very difficult to predict how a woman will tolerate one of these versus another. The last three medications on this chart are newer. They are attempts to minimize side effect. Darafenacin and solifenacin are selective to the M3 receptor, which predominates in the bladder. And trisbium chloride is a quaternary amine. The others are tertiary amines. So the idea was that it would not cross the blood-brain barrier as easily. But the clinical relevance of this is pretty questionable. Anytime it's been studied, and it's been studied very well, they all have the same side effects, and none are more effective than another. So women are often prescribed one of these medicines as opposed to another, purely based on what their insurance will cover. And here's, all of these, of course, but these are the side effects. So dry eye is by far the most common. Constipation, blurry vision, or just dry eye is a big one. And the most concerning is impaired cognitive function. So there's been more and more data showing how a woman's anticholinergic burden over time is associated with the age of onset and the severity of dementia. And oxybutynin in particular was implicated in a number of these studies. So the American Urogynecologic Society, our current guidelines are to try to avoid prescribing these medications to women older than 70, which is a large majority of women who seek treatment for overactive bladder. To avoid this, there are two newer medications available that are beta adrenergic. So the antimuscarinic medications are trying to kind of stop that parasympathetic response of bladder contractility. The beta adrenergics instead focus on the sympathetic response to the bladder and try to promote or augment the bladder capacity and bladder storage. So they work completely differently. They have no anticholinergic burden. So there's no concern for dementia, or there's no cognitive risk. Unfortunately, insurance companies are not covering these regularly, and they're very expensive. So even if they are covered, you often have to say a woman has tried 2 or 3 of the antimuscarinic medications that she may not be willing to try based on their side effect profiles before these will be covered. Anyway, I digress. So mirabegron is one of the beta adrenergics that's currently available to women. It's available in 2 different doses. It was approved in 2012. It does not work any better than the anti-muscarinics, but again, the selling point here is the improved side effect profile. There is a black box warning on mirabegron that is not to be used in women with uncontrolled hypertension because it could worsen that. It was interesting that in the dose finding studies, they did have some women who had trouble with hypertension in the 25 milligram dose, but in the 50, 100, and 150 milligram, which is not even prescribed that high, but in the dose finding studies, there was no trouble with hypertension in higher doses. So it's not a dose consistent response. So it's a little unclear how real that side effect is, but it should still be prescribing caution for women who have very uncontrolled hypertension or who are on multiple antihypertensive medications. Vibegron came out in 2020, and its selling point is that it does not have an effect on hypertension. It does not have that black box warning. It is even less consistently covered by insurance, so it's often not an option for women, but if it is covered, great. Again, it doesn't work any better than the anti-muscarinics. It doesn't work any better than mirabegron, but has a better side effect profile. It's usually very well tolerated. So now let's talk about third line therapies. So these are all procedural interventions in some way, and they're listed here, most effective to least effective. So intradetrusor onabotulinum toxin or bladder Botox is an in-office procedure that is very effective. I'll talk about in a little bit. Sacral neurostimulation is a permanent implanted pacemaker type device that is approved for overactive bladder that I place in the operating room that I'll show you some pictures of. And then peripheral tibial nerve stimulation is an in-office procedure that again, I'll show you pictures of. And when you talk about success rates for overactive bladder, pretty much all studies define success as a 50% improvement in symptoms. So we're not talking about women being 80, 90%, or even cured. We're talking about a 50% improvement in symptoms, which is really important for women to understand when they're trying to decide which treatment they'd like to proceed with. So peripheral tibial nerve stimulation, this is this little acupuncture needle. It's placed over the tibial nerve using bony landmarks. And then it is attached to a little nerve stimulator device. So women may feel a little stimulation in the bottom of their foot when this is on. They have to come into the office for these sessions. Sessions are 30 minutes long. And in order to reach maximum efficacy, they need to come every week for 12 weeks, and then once a month or once every other month for maintenance. So obviously, a woman who lives in Martinsville driving to my office for a 30-minute treatment every week for 12 weeks is not a great option for her. But it is very low risk. It seems to work. It works better than placebo, which is always good. And it works about as well as anticholinergic medications when it's been trialed in randomized controlled trials. There are some newer devices out there. So eCoin was FDA approved in 2020. And the idea is that this is a implanted tibial nerve stimulation device. So it's about the size of a quarter. And I put this picture on here because their selling point is that you could do this in the office. But I don't know many women who would sign themselves up for this in the office. But regardless, it's about the size of a quarter. Again, you use bony landmarks to place this device over the tibial nerve, and it has a little remote control with it. So it turns itself on for 30-minute stimulation treatments once a week for 12 weeks, and then you can set it to whatever maintenance therapy you want. The battery is good for at least 3 years and may be good for up to 7 to 8 years. And there's another company, Medtronic, that recently, as of last week, just got its own version of this device approved. So that's always good when there's competition because then they like to fine tune it. So I have been trained to do this. I haven't really found the perfect patient to offer this to, but if someone seeks this out, it's available to her through our office. There are some contraindications, like you can't have lower extremity edema or any kind of peripheral vascular disease, which just limits its applicability in our patient population. So then let's talk about Botox injections. So Botox works by cleaving this SNAP25 protein, which prevents the pre-vesicular release of acetylcholine into the neuromuscular junction. So less acetylcholine in the neuromuscular junction means less muscle contractility. So that's in general how Botox works anywhere in the body. For the bladder, it's injected cystoscopically. So again, no incisions. You can do this in the office. Backfill the bladder with lidocaine and wait 30 minutes, and women tolerate this very well. Look in the bladder with a little camera and use an operative channel to inject a dilute Botox solution all throughout the bladder muscle. Use 100 units of Botox. It works for about 6 to 9 months on average. But I have many patients who this will last for a whole year and they come back for yearly injections. The major downside to Botox is that in somewhere between 5 to even up to 10% of women, they will have some amount of urinary retention, not the entire duration of effect, but for a few weeks to even a few months. And it can be so bad that women need to catheterize a few times a day to empty their bladder. And that's not dangerous to them to do in any way. Obviously, we would give them supplies and teach them how to do that. But for some women, you counsel them about that risk, and they're like, no way, I would never do that. So they do have to be willing and able to catheterize in order to be a candidate for Botox. And then lastly, the last procedure available for women for overactive bladder is called sacral neuromodulation. So this is I describe this as like a pacemaker for the pelvic floor. So it's an implanted generator that will send an amplitude of electrical frequency from that little battery pack you can see here in the picture that's kind of placed right under the skin of her upper buttock along a lead that has electrodes in it that goes into her S3 sacral foramen and lies along her S3 nerve root. So this is approved for overactive bladder, urgency incontinence. It's also approved for women who do not empty their bladder well and not because there's an obstructive etiology. So, for example, an older woman whose bladder just does not empty as well as it used to, this can work for her. So there's no risk of needing to catheterize after this procedure. It's also approved for bowel incontinence, which many women who have urinary incontinence also have bowel incontinence. And it is approved in Europe for idiopathic chronic constipation. It's not approved here for that. This is how it works. So this is how I place it in the operating room. I use fluoroscopy to find, using bony landmarks, the S3 sacral foramen, and place a tiny little needle and then the electrodes through there. We look for certain motor responses. And once it's placed, that battery pack is good for somewhere between 7 to 10 years. And this is done under monitored sedation, so like even less than a colonoscopy. So it's a very low risk procedure, but it does require a trip to the operating room. This works well. So again, we're talking about 50% improvement in symptoms. But I tell women that if I do this procedure for 4 women, 3 out of the 4 will reach that definition of a 50% improvement. My experience is that initially women are much better than 50%. Maybe there's some placebo effect. Maybe it just truly works better right away. And then over the course of a couple of years, they'll kind of all even out at about that 50% improvement. So reasonable expectations are important. Okay, now we're going to switch gears and talk about UTIs. So the American Urologic Association also has really nice algorithm and guidelines that anyone can Google and pull up for free to talk about how to evaluate women with recurrent urinary tract infections. And I think most importantly is to confirm this diagnosis before you kind of go down this route. So for every woman presenting with these, I've had 15 UTIs this year. Taking a complete history and performing a pelvic exam is recommended. The pelvic exam can help exclude alternative etiologies, like maybe she has a urethral diverticulum, or maybe it's just really severe atrophy, and this is the genitourinary syndrome of menopause that needs to be treated. The other thing is to make sure that you have positive urine cultures plus symptomatic episodes. So these are not just routine urine cultures that come back positive in an asymptomatic patient, because that's just colonization. And it's not that women keep having symptoms of UTI with negative cultures, because that's more likely to be something else completely. So we're talking about symptomatic episodes with positive urine cultures, 3 and 12 months or 2 and 6, to meet this diagnostic criteria. And it's not that there's not help for women who aren't meeting this diagnostic criteria, but this is not the help they need. So those guidelines also talk about all the evidence behind our non-antibiotic prevention recommendations. Topical vaginal estrogen or estrogen cream is a big one. And the pathophysiology here is that estrogen is replacing this whole cell layer within the vagina and the lower urinary tract, meaning the urethra, the whole base of the bladder, all has estrogen receptors. So you're replacing an entire cell layer when you bring back estrogen. And in doing so, you bring back glycogen, you bring back lactobacilli, decreasing the vaginal pH, brings back all the healthy microbiome to the vagina and the lower urinary tract, which prevents the pathogenic bacteria that cause recurrent cystitis. And this is not just in postmenopausal women. That also applies to women who are breastfeeding and have lactational amenorrhea. It applies to women who have been on ultra low dose combined contraceptive pills for years and years. So there's other women to think about this for, not just the postmenopausal women. Other things that we have evidence for are cranberry supplements, not cranberry juice. That's just a whole lot of sugar. But cranberry supplements have what's called PACs in them that can bind or inhibit the binding of type 1 fibria along the bladder. D-mannose is an over-the-counter supplement that does the same thing. It's available in a pill or powder form at almost all pharmacies. Amazon sells a brand that has both cranberry and D-mannose together in a pill that's very affordable. D-mannose has actually been studied in some randomized controlled trials against preventative macrolide and did better than the preventative macrolide in preventing recurrent UTI in women. Probiotics, the data is kind of mixed, but obviously very low risk. Usually, most women I take care of are actually already taking a probiotic of some sort, so I tell them to look for lactobacillus or acidophilus strains. The next one on there, methenamine or Hyprex. This is a prescription. It is available in pill or powder form. It's converted in the urine to ammonia and formaldehyde. I describe it as like Lysol for the bladder to women. It is bacteriostatic, so it does not induce bacterial resistance. So it's a really good option for a woman who has a recurrent multi-drug resistant UTI. Unfortunately, you cannot give this to women who have chronic kidney disease, which is a little bit limiting. And it does have some GI side effects, but usually women, if they can get through them at first, initially, they'll tolerate it well long term. And then there are really very few behavioral modifications. I like to really tell women, like, this is not your fault, it's nothing you're doing wrong. But there are a few things like spermicides, managing constipation, avoiding all the weird stuff Gwyneth Paltrow tries to sell online, like douches and deodorants, and making sure they're drinking enough water. There is a role for antibiotic prophylaxis in the appropriate patient. Usually we try to do a low dose for a short course, 3 to 6 months. Postcoital antibiotic suppression also works really well. There is an OGS best practice statement that anyone can Google and look up for free that shows the appropriate antibiotics and doses to use. And then let's talk about genitourinary syndrome of menopause. So for women who either you think maybe they're postmenopausal and are having true recurrent cystitis, for women who you think this is just the genitourinary syndrome of menopause, topical estrogen is first line. Comes in lots of different forms that I've put on here. So there are creams, there's a conjugated estrogen and an equine estrogen. There are rings or inserts, there are tablets. The tablet on here of 10 micrograms a day for 2 weeks is the lowest possible dose. There is one oral medication that is FDA approved for genitourinary syndrome of menopause. It's called ospemifene. It's a once-a-day medication that insurance rarely covers, so it can be pretty expensive. And it has the unfortunate side effect of causing hot flashes, which most postmenopausal women do not want, but it is available. It is a selective estrogen receptor modulator, so it has an estrogenic effect in the vagina, also in the uterus. So it can cause endometrial hyperplasia, although has not been associated with increased risk of endometrial cancer. And it has an anti-estrogenic effect on the breast, so there's no risk of breast cancer here. DHEA is also available as a vaginal insert. This works by being converted to estrogen and typically is also expensive. So I find a pretty limited role for this. Most women are asking for this because they're trying to avoid estrogen, and that's not an appropriate reason to use that. But the good news is that topical vaginal estrogen, despite the FDA warning, has never been associated with an increased risk of breast cancer or endometrial cancer. It's been very well studied in prospective large studies in women who are high risk for breast cancer and does not increase the risk of breast cancer. So the, all of our groups have been trying to get the FDA to remove that black box warning for a long time. But for those women who still would like to avoid topical estrogens, there are over-the-counter moisturizers that are available. They're meant to be used regularly, like 3 times a week, not just a lubricant with intercourse, but as a moisturizer to truly try to increase the fluid content in the vagina. And then there are some vaginal laser devices that are available that have shown some promise in studies to treating some of these GSM symptoms and even stress urinary incontinence. They do require maintenance therapies. They are expensive. Women are often paying out of pocket. They are often advertised to women to do more than just treat atrophy. So I do kind of recommend these with caution still right now, but there is some promising research. And I think I have done it in exactly my 44 minutes. So thank you for your time, and I welcome any questions.
Not seeing anything in the chat. I want to ask a question. With the eCoin, what does that feel like to the patient? Is there, when it's going, just asking for a friend. Oh, I think you're muted, maybe?
Yes, I will. You mean once it's placed, like what does the stimulation feel like?
Yes, yeah.
Yeah, so the majority of women say they feel absolutely nothing. And those that do feel what's described as a non-painful stimulation on the bottom of their foot, like they'll feel like a little, like I think one of the words was like a buzzing sensation. I can't remember the exact words that they used in the studies, but it was never described as painful, at least from anything that they've published. Excuse me.
Okay, thank you.
Yeah.
So, Dr. Greer, you can go ahead and bring your slides up. Let me know if you need any assistance. Oh, there is a question in the chat. Can you see that, Dr. Evans, or would you like me to read it to you? Question, do you advise pelvic floor therapy first?
I'm not muted now. It depends for which indications. So for overactive bladder in particular, if a woman's coming to me with like this new diagnosis, I always try to encourage women to seek out pelvic floor physical therapy, because I think, especially if they're starting from knowing nothing about the behavioral modifications and pelvic floor strengthening, it's super helpful. I always obviously do a pelvic exam on women, and as part of my assessment, I assess the strength of their levator muscles. So if like for stress incontinence in particular, where there's not a lot of behavioral modifications other than muscle strengthening involved, if they can really recruit their pelvic floor muscles and that recruitment is strong, I mean, I obviously never discourage PT, but I'm less optimistic about the percentage improvement that one might see. Alternatively, if I ask them to, contract their pelvic floor muscles and they're like kicking me, then I think pelvic floor physical therapy with biofeedback to help them recruit the correct muscles is very effective. Hopefully
Thank
that
you.
answers. Mhm.
And Dr. Greer, just so you know, your slides look great. Okay.
Thank you.
Okay, Doctor, any final questions for Dr. Evans?
Anything in the chat?
Okay, well, Dr. Evans, thank you so much. And for the program, we'll move on to our second speaker, reviewing modern menopause diagnosis and management. Dr. Greer is also, as I mentioned, from Carilion. Her professional educational journey was mainly through Alabama, where she did her undergraduate degree at the University of Alabama, followed by her MD there. She then did her residencies in OBGYN at the University of Alabama or Birmingham, or UAB as it's known lovingly. She has a remarkable experience of teaching medical students, residents, fellows, being just an outstanding mentor. If you look at all the things she's done, it's just really remarkable. She's won numerous awards or been recognized with numerous awards for her scholarship activity and again for her teaching. So it's a privilege to have you, Dr. Greer, with us this evening, and I appreciate you doing this. So go right ahead. Thanks.
All right. Thank you so much for having me. Really appreciate this. And I look forward to talk to you all about modern medicine, diagnosis, and management. This is of particular interest to me because I am in the thick of it in my perimenopausal years, and have just recently became one of the Menopause Society certified practitioners with my exam this summer. So hopefully I can be better for my patients and my friends. I get all kinds of questions all the time. All right, and there's a lot on these slides, so forgive me if it's really small on your phones. You will have copies of these slides afterwards, so if you have any challenges seeing it, please feel free to pull it up on your computer later. But the demographics, menopause is obviously a normal and natural event that occurs. It's defined by a woman's final menstrual period, and it is confirmed 1 year after cessation of menopause. It represents the loss of ovarian follicular function, and it is the usual cause of aging. The range can be anywhere from age 40 up to 58. In the United States, the average age of menopause is around 51. Women are living longer, and we spend nearly at least 40% of our lives in the postmenopausal state. And about 60% of women will survive until at least the age of 80. And so there's so much of our lifehood that is spent in this time, and we know so little about it. So I'm really excited to learn more about it and to maybe even get into some research and see how I can help patients. Sorry. One moment. There we go. So this is just some general terminology here. Again, the natural menopause is when it's kind of a retrospective diagnosis. So it's time stamped by a woman's final menstrual period, but they need to be for 12 consecutive months with amenorrhea. So again, it's like looking back, and it's confirmed after they've been for 12 months without a cycle. Induced menopause is someone who, for whatever reason, has undergone, say, a surgical menopause where they've had a bilateral oophorectomy, potentially chemotherapy, radiation therapy, things that have caused the ovaries to age prematurely. And so this is kind of an induced or iatrogenic effect of menopause. And we refer to primary ovarian insufficiency, used to be called diminished ovarian reserve. And this is not when a woman is completely amenorrheic, but they have loss of the normal function of the ovary. It's typically before the age of 40, and they will intermittently ovulate and therefore can get pregnant, but also as a result will have irregular menstrual periods and reduced fertility. So we will sometimes see these patients, and usually it's when they're trying to be evaluated for pregnancy and fertility, and we may diagnose them with POI. Like I said, the typical age of menopause is about 51. So if we have a woman whose final menstrual period is before the age of 40, we term that premature menopause. Early menopause is someone who undergoes menopause before the age of 45. And then late menopause is someone who does not complete the menopausal transition until age 55. You'll hear us talk about, like I said, I'm perimenopausal, lovely. That's also referred to as menopausal transition. And then it is the time frame around menopause. So the symptoms oftentimes predate the final menstrual period. So that is when they're having intermenstrual irregularities, or they're feeling the hot flashes, vaginal dryness, sleep disturbances. And again, that ends, the perimenopause or the menopausal transition ends after you've been for 12 months without a menstrual cycle. And postmenopause is the time of life that is marked and time-stamped by your final menstrual period. And I have a picture here of, this is a mature follicle or Graafian follicle. And this is your egg, your oocyte that is maturing, and it's getting to the size and the nutrients that it's getting to about to ovulate. So how do we measure ovarian reserve? There's kind of 3 ways to do it for the most part. I would say most commonly, we will check an FSH in conjunction with an estradiol. This does require that patients are not on hormones, because if you're on, say, a birth control pill, it will artificially suppress your FSH. So patients need to be off of birth control pills, and then ideally it's collected in the follicular phase of the menstrual cycle, which is usually on cycle days somewhere between day 2 to 5. Oftentimes, we'll say cycle day 3. And if you have an elevated FSH, usually then 10 international units, and a low estradiol, it can be consistent with diminishing ovarian reserve. So if you remember, the ovary is producing the estradiol, and it's kind of a negative feedback with the anterior pituitary. So if you have the ovaries are not consistently functioning in diminished ovarian reserve or perimenopausal transition. So they're really trying to fire, and they're really trying to produce and make that estrogen, but they just can't. And so when there's low levels of estrogen or less than 60, it does not provide the negative feedback to the anterior pituitary. So the FSH keeps going up and up and up. And the brain is just trying to get the ovaries to fire. And so again, you'll have an elevated FSH with a low estradiol. Again, that's the one that we most commonly use. Another one that is used is anti-Mullerian hormone, or AMH. That is produced by the granulosa cells, which are in this ovary right here, that's kind of on the periphery and around here. Those are granulosa cells. They produce the AMH hormone. And the nice thing about those is that you can be on hormones, you can be on birth control pills, and it is irregardless of where you are in the menstrual cycle. And anything that is low, because again, I told you this is an ovary that's functioning, it's getting ready to produce its going to ovulate a mature egg. So if we have low granulosa cells, then we're going to have a low AMH. That AMH and the next one, the antral follicle count, are commonly used by reproductive medicine and fertility doctors to assess kind of a woman's egg quality. So antral follicle count, so this again is kind of the follicles that they're counting and measuring via transvaginal ultrasound. And again, if we have a low count of follicles, and this is the measurement of 2 to 10 millimeters, if there's not a whole lot of them, that means we just don't have a lot of the eggs and follicles remaining. So what are the menopause symptoms? As I said, they usually start in the menopausal transition. They start before the final menstrual period. Oftentimes they will include vasomotor symptoms, the hot flashes, mood swings, emotional lability, sleep disruptions. A lot of women will just be wide awake at 2 to 3 in the morning, and it's not particularly because they're having a hot flash. And we will see evidence of redistribution of body fat, many times central obesity to the abdominal wall, to the visceral organs. As Dr. Evans mentioned, GSM, which is kind of a new phrase, relatively new phrase, which includes the genitourinary syndrome of menopause, kind of a catch-all or umbrella term for a lot of vulvovaginal and bladder issues. And then patients can have sexual dysfunction. I think the important thing to know is that there is no one menopause syndrome. The vast majority of patients will come to me reporting vasomotor symptoms, however. Women will describe this as an internal furnace. It oftentimes will start in the chest, and it will radiate up into the neck and face. They'll get this flushing. It's visible too. They turn red, they sweat, flushing. They will also times have kind of heart palpitations. They get anxious. And then after that, when they're kind of nice and wet, they'll then get chills afterwards. There's varying frequency and severity. It unfortunately has a median duration of 7.5 years, but can last up to 10 years. And there is a very small subset of patients, about 10% of patients can have vasomotor symptoms for 20 years. Genitourinary syndrome of menopause, again, this is kind of an umbrella or catch-all term for the hypoestrogenic state that is involving the genitourinary system, excuse me. So vagina, vulva, bladder, urethra, those patients can present with vaginal dryness, dyspareunia. You can, of course, try non-hormonal treatments for this, but oftentimes they will require hormone therapy for it, topical. Just because a patient may have vulvovaginal atrophy and an atrophic vagina, they may not complain of vaginal dryness. So really, you're only treating the patients that are reporting symptoms to you. As one would expect, this can negatively affect intimacy and quality of life. Sleep disturbances, about a third of women in the menopausal transition will report disruptive sleep. As I mentioned, night sweats commonly in the evening time, but the sleep disturbances do not have to be associated with night sweats. They can have stress, whether it's job-related stress, social stress. A lot of these women are empty nesters where their children have gone off to college, or they're the sandwich generation where they're providing for their children, but also their parents. Marriage, relationship issues can also factor into this. I think sleep hygiene is really quite important to make sure that you avoid your phone and computer before going to bed. Alcohol can exacerbate sleep disruptions, and then other medical comorbidities such as restless sleep syndrome, obstructive sleep apnea, thyroid disease, anxiety, and diabetes. Obviously, this is no surprise that it will negatively affect one's mood, and really they can have some difficulty functioning in the next day. Cognitive changes, this is most of the time, and the biggest contributor for cognitive changes is somatic aging rather than menopausal transition. A lot of women will report to me brain fog. They have a hard time finding words. They're very forgetful. They have difficulty retrieving information and concentration. The most important thing that I can tell you is that it is temporary. It could last a couple of years, but the vast majority of time, this is just kind of a blip in the road. Patients are still able to have new learning and responding to information. So that's obviously important. Muscle and joint pain, this is commonly referred to as arthritis of menopause. Women will also oftentimes report knee pain, hip point pain, and shoulder pain. It is can be transient and self-limiting, Obviously, we need to exclude other chronic issues such as fibromyalgia, any kind of inflammatory or degenerative arthritis, medication related, whether the patient's on a statin or a bisphosphonate. Estrogen is a very complex in the joint health. It does help with metabolism and decreases inflammatory responses. Many times we recommend conservative management with pain control, NSAIDs, exercise, weight loss. However, if patients do not have significant improvement in more conservative treatment, then you can always consider adding hormone replacement therapy. Skin changes. I do see a lot of patients that most of the time when I'm talking about skin changes, it's actually in regards to the vagina and the atrophy that it goes. And so I tell patients the skin structure and function changes. This is very common where they have decreased turgor, elasticity, pliability. Things are thinner, they're more friable, easier to bleed. And so the skin on our face and hands is no different than the vaginal skin. Weight changes. Most of the time, patients don't like to hear this, but it is usually just a result of aging and our lifestyle, inactivity, and not necessarily menopause or the hormone therapy that we're adding. As many of you are probably aware, sleep disturbances can be associated with an increase in cortisol. We have lower thyrotropin, the lower leptin, reduced glucose tolerance, and decreased energy expenditures leading to weight gain. With decreasing physical activity, we are having a decrease in our lean muscle mass and increase in fat. So I really tell patients, to do weight-bearing exercises, build muscle mass, because that will help you to burn calories while you're not exercising. It also gives you support to your bone health and tries to limit any kind of osteoporotic fractures. Additionally, there's some information in regards to the gut microbiome, where we have decreased microbiome diversity, leading to a more leaky colon. And so it triggers when we absorb these microbiomes and toxins across the bloodstream, it can trigger a systemic inflammation response. And there's also some metabolic implications with the alterations in the gut microbiome. Testing and imaging. So I don't routinely draw the labs that I had mentioned previously. Some patients requested, however, if it will aid in my diagnosis, I will obtain it. If you have a patient who is a more atypical presentation, so say they're, you think that might be a premature or early menopause patient, or they have a Mirena IUD, where they're amenorrheic because of the levonorgestrel there, or they've had a partial hysterectomy. So those patients where it's not as obvious what their menstrual history is like, that might be someone who you may obtain labs in. The labs, again, that you can collect are listed there. As previously stated, an FSH and an estradiol are usually my most common. Sometimes I'll add on a TSH. Other things that are important to rule out or to have in your differential diagnosis are listed there, such as a pheochromocytoma or carcinoid syndrome. I don't think I've really dealt with those since I was in medical school, but I will sometimes occasionally have a thyroid dysfunction that I will diagnose. Indications for hormone therapy. So again, the most common one is going to be your vasomotor symptoms with the hot flashes and night sweats. If it is a particularly thin patient with a low BMI, they are at risk for osteopenia and osteoporosis. It is important to note that hormone therapy is for it's FDA approved for prevention and not treatment. It is also FDA approved for GSM and any premature hypoestrogenic state. Again, whether that's iatrogenic from surgery or chemotherapy, radiation. So timing is critical. It is everything. What we have learned from the Women's Health Initiative that came out in the early 2000s is that hormones must, if they're going to be used, they must be used in the younger symptomatic age bracket, which is the 50 to 59-year-old patients. We know that those patients that received estrogen therapy had an improved all-cause mortality and lower heart attacks. Additionally, there's less cardiovascular risk associated with hormone therapy, and we may have potential coronary heart disease and cognitive benefits, again, if we're using it within the first 10 years after the final menstrual period. Contrasting that, if we have a delayed use, which was all the bad publicity that came out with the Women's Health Initiative, it was when they were using hormone replacement therapy for patients who didn't have FDA approved indications for it. So they're using it beyond age 60 or greater than 10 years removed from their final menstrual period. And those are the patients that have deleterious effects from hormone replacement therapy. Categories for hormone replacement therapy. So really the kind of the split or fork in the road is whether a patient has a uterus or not. So if they have a uterus, you must have an opposing estrogenic effect to the endometrium. Oftentimes that opposing hormone, or the yin and the yang, it's going to be progesterone. So, so again, we have estrogen therapy alone. We have combined estrogen and progesterone systemic therapy. Occasionally, people will use progesterone systemic therapy. This is considered off-label. As Dr. Evans mentioned, there is the SERMs. There's a selective estrogen receptor modulator. And then I honestly was unfamiliar with this next one, which is a tissue selective estrogen complex. I did not really learn about it until I became recently certified. And then dihydroepiandrosterone is another form of hormone therapy for patients. So diving a little bit deeper into the estrogen-only group, we have the conjugated equine estrogen. And as you are likely aware, that's the most studied form of estrogen. That is the one that was in the randomized controlled trial of the Women's Health Initiative. And it is FDA approved for vasomotor symptoms, GSM, and again, prevention of osteoporosis. The synthetic conjugated estrogen, that is not a naturally occurring hormone. It is a plant derived typically from yams and soy products. Micronized 17-beta estradiol is my go-to, and later here in the further slides, I'll show you which are kind of my preferred options. But this is what is considered a bioidentical hormone. This is what our bodies used to make and when we were in our reproductive years. And then lastly is ethinyl estradiol, and that is most commonly used in birth control pills. So oral estrogen therapy, again, this is the one, historically speaking, is the most common form in America. As it is swallowed, it gets absorbed through the gut and undergoes first pass metabolism in the liver. So in doing so, a lot of the liver products or byproducts are revved up. Those include an increase in HDL. You will also see about a 0.25% increase in triglycerides. In regards to the coagulation factors, that is also increases. And so we see this is the likely reason that we have the risk associated with VTEs, venous thromboembolus. You may see an increase, or excuse me, an improvement in the cardiovascular changes because of the decrease in E-selectin, which is an endothelial adhesion molecule. And so that beneficially is affecting the coronary artery disease. And then lastly, you will see an increase, again, this is from liver production, an increase in the sex hormone binding globulin, SHBG. And this effectively bonds up all the free and circulating testosterone, which can decrease libido, which is already fairly decreased in these patients. So some will see that as an adverse effect. This is just a schematic of all the different types. Again, this is oral estrogen. This is the conjugated equine estrogen. As we discussed, this is synthesized or purified from the urine of pregnant mares. The next two, the synthetic conjugated estrogen, these are not considered equivalent in the US to conjugated equine estrogen. And so these next two are only approved in the US for vasomotor symptoms. So you have a little bit more of a limited benefit for those. Esterified estrogen, not one that I use commonly. I have highlighted what is my go-to for if I were to use an oral estrogen for patients. Again, this is the bioidentical, FDA approved. It goes through all the regulating and safety protocols of the US government, is the estradiol. I will oftentimes start patients on a 1 milligram dose. I like to kind of start in the middle, and then that way it gives me some wiggle room to go up or to go down. Estradiol acetate is actually no longer a prescription tablet in the US. This exact formulation comes in other routes of distribution, such as there's a ring and a patch that we'll talk about. And this here I have honestly never used, but this is just intended for you to see everything that you could offer. Transdermal and topical estrogen, again, this is going to be systemic hormones, but in a different delivery system. Comes in many different forms. There's the patch, gel, spray, emulsion. The luxury of this is that it is not, does not go through first pass metabolism of the liver. So we have more stable serum levels. You do not have the adverse effect of sex hormone binding globulin, and so you have less of a negative impact on libido. There's minimal, if any, skin-to-skin transfer to someone else. And the most important thing is that, again, not ramping up the liver coagulation cascade and factors because it's not going through the liver. So transdermal has a lower risk of VTE than oral estrogen. So if I really have my choice with a patient, I'm prescribing a transdermal estradiol. Again, this is for systemic symptoms, vasomotor symptoms. These are your transdermal options. I use the one that is highlighted there, yellow. It is a matrix patch. It comes in all different types. It can be applied once weekly or twice weekly. I specifically request of the pharmacist to give a brand called Sandoz. It's SANDOZ. Reason being is because it's a clear, very flexible patch, as opposed to some of the others that are foam, more of a skin color. They do not adhere very well. The matrix patches is where the hormone is actually in the adhesive component of the patch. And again, this is my first line treatment for patients if they're willing. Occasionally patients will tell me that it does not stick very well. Again, if you use the Sandoz brand, it sticks better than the foam one. Also, they will have some itching occasionally, a contact allergy. So what I have them do is apply some Flonase to the area where they're going to place the patch, let it dry, and then attach the patch. There are some other transdermal options, which include the reservoir patch. This one works just a touch differently. It's like a 4-layer patch where it has a drug reservoir, and it allows for a more steady state of hormone to be administered. The transdermal gel, emulsion, and spray are all daily applications. I find it can sometimes be a little bit forgetting of it, cumbersome for patients. They would rather it be something that they apply weekly, such as the 2 patches. And then lastly, this is the estradiol acetate ring. And so it is important to note that there are 2 rings out there. This one specifically is for vasomotor symptoms that has a much higher dose of hormones, and it is a systemic hormone. So if you have a patient that has a uterus, you must use this in conjunction with a progesterone agent. So moving on to progesterone, again, this is if a patient has an intact uterus and we need the yin and the yang to protect the endometrium. There is only one FDA-approved bioidentical progestogen, which is called the micronized progesterone. Again, a lot of patients are quite informed about hormone therapy now. They come in and they're specifically asking for bioidenticals, and this is my go-to for it. A lot of patients love the sedating effects that it has. It is a pill formation that they take at night, and they sleep like a baby. You do need to caution if you have a peanut allergy. And then important to note, there is no systemic topical progesterone agent. There may be some that you can get compounded, but again, typically compounded agents do not go through FDA. They're not as meeting the rigorous safety protocols, and so many times we do not recommend those. Vaginal progesterone is considered off-label. I have not prescribed that for patient. I will say that our reproductive colleagues will occasionally use it for patients with infertility treatments. And again, it'll offer you the endometrial protection when you have an intact uterus. And then on the other side of the page, we have the progestins. This is synthetically compounded progesterone-like material. Medroxyprogesterone acetate is the most commonly studied in the US. There's basically the progestins are classified into 2 groups based on structure. There's the progesterone derivatives, which is the pregnanes, and then the testosterone derivatives, which some examples are norethindrone, levonorgestrel, which is our Mirena IUD, norgestimate, and then the more potent progestogens. This is a list of combination hormone therapy options. So many times I will separate out my agents. I will separate and I'll do one prescription for an estrogen and a second one for the progesterone. But as you can see, there are medications that are combined. So they're taking a singular medication that contains both estrogen and progesterone, which can be very convenient for patients. I do find that these can be quite expensive, especially on, say, my Medicare patients, and can sometimes be cost prohibitive. The top one you will see is an oral continuous in a cyclic fashion. So this is trying to recreate the hormonal milieu that we once had in our reproductive years. So the first 14 days is estrogen alone, which kind of represents the follicular phase back when. And then the luteal phase is when we have progesterone. And so the latter half of the pill pack, days 15 to 28, is estrogen with progesterone. I don't love the cyclic ones. Women will at times have breakthrough bleeding with this. You get a better profile when patients are on a continuous combined regimen, which is the next subset. As you can see, you have the bioidentical 17-beta estradiol with progesterone, and it tells you exactly what you're getting. 1 milligram of estrogen, 100 of progesterone. This is, again, the conjugated equine estrogen. It comes in several different dosages. Just kind of put a cross right here. So you have 0.625 milligrams of estrogen with varying progesterone dose, or you have a lower dose of estrogen with a singular dose of progesterone. So there's lots of different options for these patients. And then this one I would like to draw your attention to. This is the TSEC, or the tissue selective estrogen complex. So this is the conjugated equine estrogen with benzodiazepine, which is the third generation SERM. And this is a relatively new medication. It just came out a few years ago and is quite costly for patients. And then lastly, you have a transdermal route, which again, bioidentical estrogen with the norethindrone acetate and levonorgestrel. And so these are less frequent dosings. You've got twice weekly dosing versus once weekly in the transdermal route, which again has a lower risk of clots and decreased in sexual side effects. So again, I try to use transdermal as my first option if possible. Your progestogen therapy agents, these are again intended to protect the endometrium, to decrease the risk of endometrial polyps, hyperplasia, malignancy. The top one, so it basically, we've just got all the progesterones here on the left. And then if you want to do it in a continuous fashion versus a cyclic fashion. And again, my go-to is more of a continuous combined route as opposed to the cyclic. This is medroxyprogesterone acetate, again, the most studied synthetic progesterone, norethindrone. This is norethindrone acetate. This is your micronized progesterone. This is your only bioidentical progesterone. Again, what was made by you and me, the females in the room back in the day. My go-to is the continuous fashion of 100 milligrams daily. Again, patients love this. They take it at nighttime and it significantly helps with their sleeping disturbances. And then lastly, I do also really love the intrauterine device system. This is the levonorgestrel eluting IUD. This has local effects. It is exactly where we need that progesterone. The whole reason we give progesterone is to mitigate the risk of estrogen to the endometrium. So this is a really targeted therapy to where you need it. So I like this one a lot as well. This is used off-label, so I do want to let you know that. We know that this IUD is also used very effectively for contraception and for abnormal uterine bleeding in reproductive age women. For contraception, it is FDA approved for 8 years. However, in regards to endometrial protection in the setting of hormone replacement therapy, we know it's good for 5, but from years, beyond 5 to 8, it's a little bit questionable as to its activity at suppression of the endometrium. Next estrogen option is the SERMs, or the selective estrogen receptor modulators. These their effects are dependent on the target tissue. So they can have both pro-estrogenic or anti-estrogenic effects depending on that final tissue. They bind like estrogen to estrogen receptors alpha and beta subunits. There's multiple different types of SERMs. Benzodoxaphene, ospemifene, tamoxifen or loxafen, and torimifene. There's also naturally occurring SERMs. So we don't routinely recommend those, but I do have patients who really do not want hormones or have significant contraindications to them. So naturally occurring phytoestrogens that are in our foods. Some of those include lentils, peas, chickpeas, flaxseed, bean, soy products, soy milk. Bazodoxaphene is a third generation SERM. It has pro-estrogenic or agonistic effects to the bone. So in other countries such as Japan and Europe, it is approved for the treatment of osteoporosis, but here in the US, it's only for osteoporosis prevention. It has antagonistic effects to the breast and the endometrial tissue. And again, so therefore it is helping mitigate risk of polyps, hyperplasia, or malignancy. It improves vaginal dryness and sleep, and it does have a black box warning for patients who are at high risk for venous thromboembolus. Let's see. As I mentioned, it is a combined vasodoxifene is combined with a conjugated equine estrogen, and that unit is called a tissue selective estrogen complex. So this is when a patient has a uterus, an intact uterus, and for whatever reason they do not want to use progesterone, this is an option for them. It is only approved for vasomotor symptoms and osteoporosis prevention in the US. So it is lacking the approval for GSM. Additional SERMs, you have probably heard of raloxifene. This is approved for osteoporosis treatment of the spine. It is a second generation SERM. It has pro-estrogenic effects to the to the bone, and minimal effects to the endometrium. Therefore, it has lower risk of uterine cancer. It has a lower risk of VTE and cataracts when compared to tamoxifen. Probably the most common SERM that I encounter in my practice is going to be tamoxifen, which is used in the US for my breast cancer treatment and prevention patients. As you know, it is a potent anti-estrogenic effects to the breast. And it has estrogenic effects to the bone, liver, and uterus. So I do have to closely monitor these patients for endometrial thickening, any kind of hyperplasia. I have one in my practice at the moment. So non-hormonal options for vasomotor symptoms. Obviously, weight loss, you'll hear that. It's all over the place. It's something that patients can actively do. It has many benefits beyond the vasomotor symptoms. Herbal supplements, I used to talk about black cohosh and evening primrose. Those are not typically recommended. There are some modalities such as hypnosis and CBT, which is cognitive behavior therapy, that will sometimes help patients. And then there's other pharmacologic agents, certain antidepressants, such as SSRIs and SNRIs, fezolinetant, which is more recent. That is a neurokinin B antagonist, which works at the brain level, which is near where the thermoregulatory center is. Gabapentinoids can be used. And then oxybutynin, which Dr. Evans talked about as well. That's an antimuscarinic or anticholinergic medication. I will caution you again because of the side effects that we can see with dementia, and there are some cognitive declines in perimenopause, so caution with that use. Non-hormonal therapies for GSM. Again, this is a slight overlap with Dr. Evans's talk, but vulvovaginal lubricants and moisturizers. Many times patients are using the lubricants typically around intercourse. You can get them over the counter. Typically recommend silicone-based products. They need to avoid alcohol based products. I tell patients, if you look at the back of the container, the box, the label, if it ends in an OL, just like alcohol ends in an OL, you probably need to avoid it. I kind of describe it when we use alcohol astringents to our face, they kind of dry it out over time. Same thing with the vagina. Moisturizers, again, those are something that are used daily, and it's in an effort to improve the water content in the vagina. Pelvic floor physical therapy, I will commonly send my patients over to the urogynecology office. They have some amazing physical therapists over there that work with patients for controlling kind of relaxation techniques and maneuvers. They can also assess with vaginal dilators. If patients have significant dyspareunia, they're not using it. If you don't use it, you lose it, and they can have contractures and stenosis, and so dilators can help with that. And then we will sometimes also use lidocaine before intercourse, or if they're using a dilator. Hormone therapies for GSM. I would say ideally this is a local problem, so we try to either a non-hormonal route or we're using local treatment. If patients, have other reasons for systemic hormones, we will see occasionally some benefit for GSM with systemic hormones. And again, a little bit of overlap here, but the DHEA insert and then the oral third generation SERM is available for GSM. Local vaginal estrogen therapy. Again, this is comes in several different options. This is topical. These are all going to be treating a local issue with local solution. So we have our vaginal cream, 17 beta estradiol. This is my go-to, again, highlighted in yellow. Loading dose is typically nightly for about 2 weeks if they have really bad symptoms, dyspareunia, atrophy, sensation, dryness. And then the maintenance dose is usually 3 times weekly. Many times I'll tell my patients Monday, Wednesday, Friday, Tuesday, Thursday, Saturday. This is the conjugated equine estrogen, similar kind of loading and maintenance dose. There are also 2 vaginal inserts. This is the 17 beta estradiol. It comes in an ultra low dose regimen. They are going to use it nightly for 2 weeks and then twice weekly. These patients who don't like the mess of gels and creams will oftentimes use the inserts as their second choice. I will say, since there is no generic available, this can be quite costly, and this one can be a little bit more affordable for patients. And then when I was talking to you about the vaginal rings, this is the ring. Again, it's a bioidentical. This has a much lower dose of hormone, and this is intended for local treatment. So you do not, in all of these topical treatments, you do not require progesterone for protection of the endometrium. There's 2 daily non-estrogen therapies, which is the DHEA insert. It has an applicator, and you use it nightly, fairly routinely. And then the ospemifene, or the third generation SERM, is the only FDA-approved oral tablet for GSM. Again, there's no generics available for these, and I can honestly say I don't think I've ever prescribed them for patients because of that. Let's see. This is the DHEA insert. Again, I think I've covered most of this. Approved really just for GSM, for moderate to severe dyspareunia. It basically has the androgen gets absorbed into the associated vaginal tissue, and it gets aromatized into estrogen. It's nightly. It has fairly stable, normal postmenopausal levels of estrogen. So again, it's not getting into a high level that requires progesterone for the endometrium. It also improves the lubrication, arousal, orgasm, and pain for patients. Ospemifene is your SERM. This again is the only FDA-approved oral medication for GSM. As Dr. Evans mentioned, it will have a transient increase in vasomotor symptoms, which obviously patients do not appreciate, but it seems to be transient. The black box warning is there is a slight increased risk in hemorrhagic stroke and VTE. So if you have a patient that is undergoing surgery or immobility for whatever reason, you will need to discontinue it for a minute. So systemic hormone therapy for GSM, again, I think the drive home point that I want to make is it's not usually your first line for GSM. The reason the patient demographic that you would use systemic hormone therapy for would be someone who has concomitant vasomotor symptoms, if they have premature menopause, or they're at significant risk for Our go-to medication for this patient, again, is that low-dose vaginal ring because it's giving the needed medication to the area of interest, but then you can also have it for systemic benefits. Occasionally, systemic estrogen therapy is not sufficient completely for resolution of GMS symptoms. And so if you put them on systemic hormones and it's insufficient, they're still having dyspareunia or dryness, you can add on some topical agents. Again, I try to use the transdermal because it has a lower risk of decreasing their libido. So who do we not use hormone therapy in? Obviously, you want to make sure it's a patient who doesn't have any unexplained vaginal bleeding. They don't have postmenopausal bleeding. Obviously, if they do have that, you need to evaluate it before putting them on medications. If they have any estrogen-sensitive tumors, such as a breast, ovary, or endometrial, they're not a candidate for estrogen therapy. Also, patients who are ER/PR negative or HER2/neu negative patients and they've completed 5 years of treatment, or not 5 years of treatment, but they have been disease-free for 5 years. They've completed their treatment. You could consider giving them some hormone therapy. By all means, when I have these patients, I am doing shared decision-making with the patient and their oncologist. I would say the vast majority of these patients are going to decline hormone replacement therapy. If a patient already has coronary artery disease, any stroke or MI, they are not a candidate for hormone replacement therapy. If they have a personal history or an inherited thrombophilia, it's a no-go for them. If they have an active liver disease, again, that's more from the oral agents where they undergo first-pass metabolism of the liver. And then if you have a peanut allergy, you cannot have medroxyprogesterone acetate. So coronary heart disease and hormone therapy, this is really revisiting the timing hypothesis. We have seen in the Women's Health Initiative, if you are administering hormone therapy, it needs to be done ideally when patients are symptomatic in their early 50s. And we know that those patients actually have improvement in their symptoms. It has shown the initiation of hormone therapy in recently postmenopausal patients has no effect or a reduced effect on subclinical atherosclerosis and coronary artery calcifications. So I think the important thing here is that they're asymptomatic. If you have a patient who has had the MI or a stroke, they cannot go on hormone therapy. Additionally, if I have patients who hopefully are current with their PCP and they have fasting lipid panels, I will look at those and make sure they don't have any hyperlipidemia, dyslipidemia, they don't have any pre-existing cardiovascular disease. Venous thromboembolus and hormone therapy, I think I've touched on a bit of this already. So ideally, we're using non-hormonal options as first-line treatment for these patients. If you have a history of a VTE, under no circumstance really can you have systemic oral hormone therapy. If you have an underlying thrombophilia without a personal history of DVT, that's a relative contraindication to hormone therapy. If there's a family history of VTE, it's recommended that that patient undergo a thrombophilia evaluation before starting treatment. Again, low-dose transdermal hormone therapy has not been associated with an increased risk of VTE. And then very off-label, if you have a patient who has persistent vasomotor symptoms that's unresponsive to non-hormonal therapies, you could consider a transdermal hormone if they are adequately anticoagulated. Again, I try to steer clear of that. See a question popping up. I'm almost done and we will get to that question. So when to stop? I will tell you, I struggle with this. It is very individualized. It is a very shared decision-making process that I have with my patients. Depending on the source and where you go, You know, 60 is sometimes that number where I'm really probably trying to decrease the dosage, if not discontinue it in all. We know that at least half of patients will experience recurrence of their symptoms when we discontinue. So therefore, I really try to titrate or actually taper the patient down off of the hormones. I try to do it in the winter months when it's cooler. And then again, there's really differing results on this. I can tell you if I'm using prolonged hormone therapy, I really try for it to be estrogen only because it's the workhorse. And secondly, a lot of the adverse side effects that we see with prolonged exposure is from the progesterone component. And then lastly, you can continue to use local low-dose estrogen for patient with GSM symptoms. And that does not have to discontinue at any age, really. And I believe that's it.
So
In
can
the
you
chat.
see that question in the chat? Would you like me to read it?
I would. I saw it when it popped up, and since it has gone bye-bye. So if you could show it to me, that'd be great. Or
Sure.
tell me it.
For patients on tamoxifen, do you have a routine screening process for the thickening of the endometrium? And also, how do you feel about smokers taking HT?
Yeah. So I do not have a screening. In fact, it is not recommended that we have a screening. I will say that commonly I will come up with a excuse to get a transvaginal ultrasound. And so in a postmenopausal patient, ideally the endometrial lining is less than 4 millimeters. There is data to say that if you can accept it up to 10 millimeters and not do an endometrial biopsy. I tend to be proactive. So if I have a tamoxifen user and they have any kind of postmenopausal bleeding, I will for sure get an ultrasound and have a very low threshold for an endometrial biopsy. But there is no transvaginal ultrasound that is done for surveillance for those patients. And then in regards to smoking, it's not an absolute contraindication to hormone replacement therapy. I would say that is definitely, however, a patient that I'm probably screening for cardiovascular risk factors. So I'm getting fasting lipids on those patients. I may have their PCP weigh in on any kind of other potential risk factors, but you can use it. I would also tell you transdermal is the route to go for that patient.
Any other questions, Mary, in the chat?
No, that was it, Dr. Moore.
Any other questions from anyone on the call? Dr. Evans is still with us also. If there's any late breaking thoughts about her presentation. Okay, well, for both of our speakers, we are very grateful for the time you shared with us this evening, and I know the large amount of effort you made in preparing the talks. This was really a really nice program, and thank you so much for doing this. I hope that everyone on the call tonight will gather with us again in 2 weeks when Neil Lewis, one of the attorneys at Hancock Daniel, will be updating us on medical malpractice in the Commonwealth of Virginia, sort of what's old, what's new, and what we need to continue to be working to avoid and prevent. So for that being said, thanks for everyone being on the call. Mary, thank you for your management, and to our speakers, another great big thank you. Everyone have a great night, and we look forward to seeing you back on our next program. Take care. Bye-bye. Good evening.
Thank you.
Bye. Thank you.
Thank you. Thanks, Dr. Evans. Thanks, Dr. Greer.
Thank you.
Thanks.
Bye.